Mic test. Mic test. Hello? Okay, is it working now? Is the mic working now? Or no, is it not working? I don't know. I know why. Okay. Okay, there we go. Okay. Okay. Yeah. Alright, so hello and welcome to the stream. If you hear any high-pitched growling or angry noises, it's my sugar glider, because I have my sugar glider. I have the pouch of my sugar glider around my neck, so yes. Good morning, Dr. Shiori. Hello. It is afternoon here, though. It is like 3 p.m., 3:17 p.m. So good afternoon to people who live in this time zone. Good morning to those who live in the other side of the globe. And good evening to whoever is living in at night. I don't know. Tara, kape. Ayoko magkape. I have Alt F4 with me right now. Anyway. Yeah, my sugar glider's awake. He woke up because I had to, like, move him from the spot he was in. Because when it's, like, daytime, I put my sugar glider here near where the PC is. So now that I'm streaming, I have to move him. And I put him around my neck. And he's just looking at me like, why you noisy? He's look at me, you noisy. Ba't ang ingay mo? The time zone, how's that possible? Yes, we live in the future. The Filipinos live in the future. Wait, hold on. So anyway, we are doing, so last week we talked about going anal, or we talked about the anus, yeah. We talked about benign diseases of the anus, yeah. So, right now, today, we'll be talking about malignant anus. Malignant, or basically cancer, okay. So, cancer is not an easy topic to talk about, especially anal. I don't know, actually, when I was making this PowerPoint, I was wondering how I am going to simplify this, because there were a lot of, translating cancer, anal cancer into like stuff you would understand is kind of hard. I can't have too many pictures either, because here's the thing I noticed about YouTube. Yes, I can post, like, I can make educational streams without any censors, but the problem is if it shows gore or something like that, gory shit, I don't know. If it gets too bloody, basically, YouTube restricts my videos to 18 and above, mature audiences only. Okay. And I think that's what happened to one of my past medical education streams. I think, wait, which one was it? There was one medical education stream that got restricted. I mean, you can still watch it as long as you're like 18 and above, but if you're like not subscribed, or no, if you're not logged into YouTube, you can't see it. Yeah. Even one of my shorts got restricted. I don't know if you saw my latest short, the one about the Tekken men thighs. So I posted that short, or that reel, on Face. Did I post it on Face? I think I posted on Twitter. I posted on Instagram and TikTok. I posted on YouTube. YouTube restricted it. I don't know why. I think they don't like. I think YouTube doesn't like men's thighs or something. I don't know. It doesn't. YouTube doesn't like men's thighs for some reason, or Tekken men thighs. It got restricted, but it's like you can only see the short if you're 18 and above. If you're not logged into YouTube, or you know, if you're not 18 and above, you won't be able to see the short. Or you're like, it'll say mature audiences only, something like that. Freaking YouTube. Alright, so anyway, hopefully, because of it, for this, may shorts pa, wala, syempre walang shorts, nakabahag yung mga Tekken men. Anyway, so, for this topic, teka lang, wait, let me fix this. YouTube. Okay. So, this topic is a little tough to talk about because it needs pictures. Okay, this topic needs pictures for you to visualize, but I decided not to put pictures here because it is pretty gross, and even though it is allowed on YouTube, YouTube might restrict this stream and make it to 18 and above, mature audience only. So, if I'm gonna, you guys, if I tell you to search a certain cancer, or if you want to know how a certain cancer looks like, you're gonna have to Google it and just look at the pictures. Okay, yeah, so this topic is anus the second. We're gonna talk about the anus again. Okay, I'll keep this short. Okay, I'm gonna keep this short. Nope, I won't search that while in the office. Wala po, then you won't learn anything. You ain't gonna learn anything. Okay, alright, let's go. Okay, so anus, we're gonna go back to anatomy, okay? Remember last time we talked about the anatomy of the anus? We're gonna go back to anatomy because that is very, very important in cancer. When it comes to cancer, whether wherever it is, if it's an anal cancer, if it's a colon cancer, if it's a breast cancer, lung cancer, you have to know the anatomy of the organ, or the locate, or the anatomy of whatever the cancer is affecting. Most especially the blood vessels, or the blood supply. So yeah, this is this photo I showed last time. So I told you guys, this is the anus, okay? So this right here is the anal canal, okay? The anal canal, this is the anatomical anal canal, and then this is the surgical anal canal, which is above the dentate line. And then we have this part is the rectum. Okay, so the anus is just this. Anus measures, surgical anal canal just measures around 5 centimeters. So from the anal verge, which is this, 5 centimeters above, that is the whole anal canal. Okay, these ridges over here is the dentate line. Okay, where we have also where the anal crypts are, the anal glands are, and the anal columns of Morgagni. Okay, and the muscles, we have the internal sphincteric muscle and the external sphincteric muscle. Okay, the external sphincteric muscle is the one that you control voluntarily. So when you clench your butt, this is what you're contracting. This muscle right here, the external sphincteric muscle. Okay, the internal muscle is the one you can't control. Okay, and then the little blue ones here, if you remember, those are the hemorrhoidal cushions. Okay, these things. Okay. Now, so that's like the anatomy. If we're gonna talk about blood supply though, see this? This right here. And this, especially this. I'm only showing the arteries, by the way, okay? I'll only show the arteries because that one is the more important one. But veins are pretty much like mirror this or something, or parallel. So this is very important to us surgeons, doctors. Imagine being in med school and you have to memorize all of these. And this is just in the area of your pelvis, guys. And only one or two types of organs. The anus, the rectum, and then the sigmoid colon. Okay, this, by the way, is back view. Okay, this is back view. Because if you're looking at a person from the front, this sigmoid colon is supposed to be like, paganon. It's supposed to be here. But this looks like it's the back. It is the back view. Because this right here, the iliac arteries are positioned at the back. Okay? So this one right here is your aorta, and then it branches into your iliac arteries, which also further branch into all these, into all this shit right here. Okay. Basically, the stuff we need to know when it comes to anal cancer, we're supposed to know the blood supply of the anus and rectal, or at least the anal rectal area. So that would be this. So, you know, the rectal arteries, we have the right inferior, right middle, right internal pudendal artery, the rectal accessory middle rectal arteries, and all that shit, okay? But this is just the right side, okay? There's also the left inferior rectal arteries, left middle rectal, you know, just like that. Okay? So basically what we need to know is that the anus and rectum are supplied by basically the rectal arteries, inferior, middle, and then which branch from the iliac arteries right here, or more like your iliac arteries. We have to know this. They ask this a lot. This kind of question they ask a lot. I don't remember if they ask this in like med students. They probably do. Med students will most probably know this, but like if you ask like doctors who are not surgeons or do not specialize in this area, they won't know, they won't remember. Okay. So, ayun. Here. Okay. Superior rectal arteries branching from the inferior mesenteric artery, which comes from the aorta, yada yada yada. Okay? This is why I'm not a doctor. Memory of a goldfish among a lot of other things. Yeah, this thing is I'm telling you guys, even as a surgeon, this is so it's confusing, but we gotta know this, especially when we're gonna do surgeries. It's important to know these, by the way, if you're doing surgery, especially when you're doing surgery for cancer, because when you do surgery for cancer, you don't just remove the cancer. You have to remove a certain part of the organ. Like in anal cancers, you're going to remove this thing. This whole thing here. Actually, this whole thing. When you do cancer for the anus, you're gonna remove the rectum. Pretty much this much. So you have to know which arteries you can ligate or which arteries you can cut and which you shouldn't cut. Because if you cut the wrong artery or ligate an artery you're not supposed to, for example, let's say you're doing a surgery for this and you ligate this artery right here. Here, you ligate this. This artery, if you can see, it supplies the descending colon right here, right? And it also supplies the sigmoid colon. Aside from it also supplying the rectum. So if you tie this up, that means your resection or your surgery is gonna you're gonna be ending up doing it higher. You will have to cut the organ higher up until, because if you leave, let's say you cut this and then you only remove this part of the colon is gonna die because it doesn't have a blood supply. Okay? My paternal grandfather passed away from colon cancer in the 2000s, so this is a good opportunity to learn about it. Yeah, actually, we're gonna focus on anus only. We're gonna do colon and rectum another time because because the anatomy is different and the management is different. So, we're gonna do anus first. Next time na yung, colon and rectum. I'm gonna put colon and rectum together. Or I'll try to anyway. Duck, what would you do if while operating on arteries you puncture one of these? Either you have to repair it or ligate it. Depends on which artery you injured. It depends on which artery you injured. If it needs to be repaired, then it has to be repaired. Alright, symptoms of anal cancer, okay? It's very similar to last week. So, it's very similar to benign diseases of the anus. So, number one is bleeding. Okay? So, when you defecate, there will be bleeding. Or sometimes most of the time, it will be like bright red. Or at least a dark red. Dark to bright red. Depending on how far, but if it's anus, it's most likely gonna be bright red. If it's the anus, it's bright red. The darker red it is, the higher up your cancer is in the colon. So since we're talking about anus, it's gonna be bright red. It can be like hemorrhoids, the blood produced by from bleeding hemorrhoids. It looks the same. So you could be pooping fresh blood. Or you could be having blood streak stools like a poo-poo with some ketchup or blood. Okay, so one of the most common symptoms. And then also pain. Pain is a common symptom as well. So, especially when defecating. So it's very similar to like hemorrhoids or fistulas or fissures. It's similar, the symptoms. But in anal cancer, you would also have changes in bowel habits. This one's another one. Changes in bowel habits, like, you know how normally when you poop, you you know how your poop looks like normally, and then you notice there was a change, like you're having diarrhea or having constipation. Okay? And wait, what's this? Yeah. And most of the time, if you have anal cancer, it's anal cancer is you have may bukol ka, diba? You have a mass in your anus. So most of the time, it presents as constipation. You're having difficulty pooping. You have difficulty pooping. So it'll present as constipation most of the time. There are times it does present with diarrhea, but most of the time it's constipation. Okay? There's also a feeling of a lump or a mass on the anal area. It's kind of like hemorrhoids, but anal cancer is harder than hemorrhoids. Hemorrhoids are soft and fleshy. Soft, fleshy, and bloody. Anal cancer is hard, painful, and bloody sometimes, but yeah. Okay? So, physical examination. So far, do you guys have any questions? I'm gonna take a sip from my alcohol. Ihandang Gatorade Blue. Gatorade Blue tapos pag naghalo sa red, that's gonna be like blue plus red. You have purple stools or something. Okay. No questions, I guess. We'll go on. So, physical exam is also the same as last time. Remember this, guys? Digital rectal exam. You remember this, right? So, do you remember you remember how it's done? So, class, you can try practicing with your other classmates how to do this. You guys know. But yeah, basically, when we what do you call this? When we do a physical examination and we suspect a mass in the anal area, it is important to do a digital rectal exam. Had it done on me. Okay, see features. So you know how it feels to have your... Okay, so yeah, they do this in ano yan? Annual physical examination. So some APEs they have this. So yeah, if you've had it done to you, now you know how it feels to have a finger up your butt. Pre-employment exam final bus. Yeah, you know how it feels to have a finger up your butt. It is part of the APE. I remember having this, and they were going to do a digital rectal exam on me, and I refused. I said, no, I don't have anything up there, no. So the doctor didn't do it. I escaped from it. I escaped from a DRE. Kapag masama ugali nung nag-exam, hinlalaki ang gagamit. You can't use the thumb though, it's too short. You won't reach as far as you're supposed to reach. Weirdly, it's because of appendicitis, so I didn't get to save it. Oh, okay, yeah. Sometimes when patients have appendicitis, some people do that. Some people do a digital rectal exam. It is actually done sometimes. Personally, as a surgeon, I don't really do it often. The only time I will do that is kung malabo yung pain. Like when I'm palpating the patient's abdomen and I cannot elicit the kind of tenderness I'm looking for. The next one I do is like that, digital rectal exam. Dok, pwede to? Ano yung nails? God, I've never had nail polish or any of those acrylic nails and shit because, I'm a surgeon. You're a surgeon? Yes, I am a surgeon. Surgeon? Yes, I'm a surgeon. A general surgeon. Okay. My gloves. Yeah, but even if you have gloves, you cannot use, even when you have gloves, you can't have this kind of nails on because they can tear the gloves, you know? May Wi-Fi support kasi digital puti. Reset. Okay. So, yeah. Alright. Most of the time, when a physical, like, so, wait, what's the next one? Okay. Ito. And then this, remember this, I showed this to you guys last time too. There, you also do, most of the time, it's an anoscopy. Since we're talking about anus, you only need an anoscope. So, this is, for this, to examine the anal canal and to see if there's a mass or anything. So you just insert it, you pump it up with air, you insert it, you remove the obturator, you pump it up with air so that gas is inside so you can see, and then you slowly pull it out while looking in. Okay. So, what is the next slide? Okay. So in a typical patient, well, typical, okay, quote-unquote typical. If a patient comes, who is suspicious of having an anal cancer would be usually it's an older person, okay? So like elderly, it can be 70s, okay? And then they will tell you, they will usually come saying their chief complaint would be may dugo sa puwet. I poop blood. They would say, I have blood in my butt, or I have been pooping blood. Or it can be, I am having a hard time pooping. Or I feel parang may bukol ako sa puwet. They would say something like that. Okay, so they would complain about that, and then when you ask them, oh, so how long has this been going? Typically, they would say since a few months ago. If it's earlier, they'd say it started a few months ago. They would notice they had weight loss, like unintentional weight loss. They would lose weight, a significant amount of weight. They would say when they poop. So there would be times where it's fresh blood. There would be times when it's blood-streaked stools. There would be times also that they would say, the shape of my poop changed. So one of the descriptions I used to use a lot is nanipis. If their stool got thinner, like we call it pencil-like stools. So nanipis ba yung dumi nyo? Naninipis ba ang dumi nyo pag dumatae kayo or kung dumudumi kayo? It's like, it becomes pencil-like, and then they would say, yeah, notice that it's got thinner. Or, ano ba? Yeah, parang ganun. And also, sometimes, they would, even without defecating, they would notice the blood. Or anal pain. Anal pain is common. Masakit yung puwet. May nararamdaman akong bukol sa puwet. Yeah, that stuff. So, that is part of the history. And then, we do a physical examination. So, most of the time, the important physical examination, aside from the DRE, okay, is palpating the abdomen. Because if it's an obstructing mass, their abdomen would be distended like a balloon. It will be parang lobo. Lumalaki ang tiyan. Distended, gassy, tense, you know. Sometimes there will be pain. Sometimes you'll be able to feel a mass in the lower part of the abdomen. So it depends. Sometimes you don't feel anything. So it really depends. Okay? Sometimes there's nothing in their abdomen, but everything is just in their butt when you do a DRE. Okay? Sometimes you have to do this. The scope, the anoscopy. Okay? Nice free medical lecture from a VTuber. This is not my 2025 checklist before. Yeah, I do medical education streams. Mostly surgical. When I do at least once a week starting this year. I used to do this a lot before, like once a month when I was still busy in residency. Now I'm doing once a week. I try to anyway. Whew. Okay. Alright, we're gonna move to types of malignancies. Do you guys have any questions? Before we go to the types of malignant or pre-malignant anal lesions. Man, Alt F4 is better when you have ice in it. This one doesn't have ice. So this is where alien probing comes from. What the hell do you mean by alien probing? Goods lang ba? Okay. Alright. If there's no question, okay, we're gonna proceed. Okay? I am going to be mentioning some, or no, not some, or at least whatever's on the textbook that we study. Textbook anal malignancies or pre-malignancies. But I'll tell you which one are the most common ones that I've seen in my practice. Okay? Or in my years of being a surgeon. Okay, HPV. This is a very, very important risk factor, or not just a risk factor, and a very, very important virus that you need to stay away from, guys. HPV. Oh god, I'm sorry I did not fix my slides. Okay, I didn't fix the slide, but anyway. So, HPV is the most common sexually transmitted infection in the US, okay? I'm not sure about here in the Philippines, but it's probably similar. Okay. There are the most common there are different types of HPV. They have subtypes. There's like 100 or so subtypes. So there's like HPV 1, 2, 3, 4, 5, 7, 100 plus. Okay? So a certain subtype of HPV is related to or increases your risk of developing certain cancers. So like subtype 16 and 18 increase your risk of developing squamous cell carcinoma of the anus. Okay. Levels for it. It's not levels of HPV, it's just different types, subtypes. Okay. Now, remember last time we talked about anal warts? Okay, we're gonna talk about now the HPV related ones. So, condyloma, someone mentioned last time, someone mentioned condyloma. So we're gonna talk about condyloma acuminatum, which is anal warts related to HPV, and usually it is caused by HPV subtype 6 and 11. Okay? If you are a med student or planning to be a surgeon, this thing, the subtypes, they ask this in exams, I'm telling you. They ask this in exams. What subtype of HPV is related to anal warts? And you're gonna have to know, oh, it's subtype 6 and 11. What subtype of HPV is related to squamous cell carcinoma of the anus? The answer is 16 and 18. And they'll give you so much, like, choices, man. You got the preview. Alright. Okay. Alright, so... Okay. There's also this, the Buschke-Lowenstein tumor. I don't know how to pronounce it. Buschke-Lowenstein tumor, or verrucous carcinoma. It is a giant condyloma acuminatum. Remember last time I said, if it looks like a cauliflower in your butt, it's anal warts. So this one is the giant one. Okay? Imagine this is in your butthole, okay? Imagine this on your butthole. Imagine this, but flesh-colored. That is a giant condyloma, or a Buschke-Lowenstein tumor. Like inside, it can be it can be inside or growing out of the anus. Remember, the anus is a canal, so it can be growing inside, and because it grows so big, it can, you know, stick out of the hole. Right? I used to like cauliflower until today. I'm sorry, but that's exactly how it looks like. Actually, I've seen one. I have seen anal warts that look like leaves, like tiny leaves. I have no... I forgot what type of anal warts that was, but... yeah, it looked like leaves. Let me see. Maybe I can find it. Anal warts that look like leaves. Like, there was a picture of it. Oh, there it is. This one looks like leaves. I think this is I think this is not, I think this one is not HPV related. Holy crap, what is this? Kadiri to. Oh my god. Oh, that's hemorrhoids. What the heck? A melted wart. Oh my god, I just found a picture of a hemorrhoid and it has an anal wart. There's a picture. I found a picture of a hemorrhoids. Like, someone has hemorrhoids and there's a freaking anal wart growing out of the hemorrhoids. May hemorrhoids na nga, nagka-warts pa. Kawawa naman yung pasyente. That is so weird. Imagine a hemorrhoid and then you have a freaking cauliflower growing out of it. That is so sad. Kawawa. Kawawa naman. Okay. Just like the fungus zombie fruit. Actually, yeah, it is kind of like that. Imagine the Last of Us type of stuff growing out of your butthole. That's it. Okay. Alright, so... yeah. Alright, next. Anal intraepithelial neoplasia, or AIN. Okay. This one is a premalignant lesion. Wait, oh, before I get there, these things, the warts, are premalignant lesions, by the way. Okay? They can lead to cancer. So if you have anal warts, you are at risk of developing anal cancer. So they're not cancer yet, but you have the risk of developing anal cancer. That's why this is a very important risk factor. You gotta avoid this. Avoid HPV. Okay? Have safe sex, everyone. Okay? And you know how it goes, guys. If a man has anal cancer from HPV, like one of the risk factors, if it's HPV, more often than not, wait, I think I have it here. More often than not, it's an MSM. There we go. Look at that. MSM, just like this. This is a premalignant lesion for anal for squamous cell carcinoma of the anus. So risk factors, again, HPV, HIV positive status, MSM. You guys know what MSM is? Do you guys know what MSM is? There's also smoking, cervical dysplasia for women, okay? Cervical dysplasia. So sometimes they have to, women who have, who are at risk, they need to undergo a pap smear of their cervix. But yeah, one of the MSM. I don't know if you guys know, but basically it is male on male action, okay? Very common. Like, most of the patients I've seen that have anal warts are they're not straight. Basically, majority of the ones I've seen, they're not straight. They are not straight men. Okay, so as for a picture of this, I could not provide any because YouTube might restrict my video, but you can search it up. So, intraepithelial neoplasia. It's basically like a tiny bukol sa puwet. Parang ganun. It's like a small mass, small lesion in the butt. So yeah. Okay. Alright, next. Treatment for this. So they have topical treatments, okay? You can put one of the treatments for this imiquimod cream. I think I mentioned this is also for anal warts. They have 5-fluorouracil, and then there's also trichloroacetic acid. I've never seen this in real life, because when we deal with anal lesions as a surgeon, we're up surgery. Straight up surgery. So I haven't actually seen this yet so far. Okay? Other management, we have radiofrequency ablation, infrared coagulation, electrocautery. You basically just burn them because they're still small. You just burn them up. Okay? And then lastly, sometimes if this doesn't work, you have to excise them surgically. Remove them, okay? Oops. What is that? Oh no. Okay. Alright, next. So since before we the next topic kasi, the next disease after this is straight up anal squamous cell carcinoma of the anus. So that's like the actual cancer. I'm gonna talk about staging, okay? I'm gonna talk about staging. Because I think when you guys think about staging in cancer, you guys think of stage 1, 2, 3, 4. 4 is the worst one. 4 is kalat na, right? That's what most of you know. Like, the higher the number, the worse it is. The lower the number, the better it is. Yeah? So, staging of cancer, not just anal cancer, but any cancer, is a bit more complicated. It goes deeper than that. It is more complicated, and we as doctors, especially surgeons, we need to know all this. See, this is the one. You guys only know like stage 1, 2, 3, 4. There's also ABC. There's also like stage 1, stage 2A, stage 2B, stage 3A, stage 3B, stage 3, and stage 4. Sometimes there's even more in other types of cancers. Like there's stage 1A, stage 1B, stage whatever, A, B, C, D, E, F, G, and we don't just we get to this type of stage based on the TNM. There's also like a mini staging, like TNM. Okay, T means the tumor, usually means the tumor size. Okay, N is the lymph nodes, so the lymph nodes, like where it is. M basically means metastasis, if it's invaded other parts of the body. Okay. So, if we say, for example, this patient's tumor is a T1 N0 M0. T1 N0 M0. So that means T1, the patient has a tumor in his anus that is less than or equal to 2 centimeters. Okay, so it's a small tumor. It's 2 centimeters, up to 2. N0 means he has no, walang kolani. It has not scattered to other lymph nodes. M0 means it hasn't scattered to other organs. Right? So if you have a T1, N0, M1, that's a stage 1. So that's early stage. Okay? If we say, let's say the patient has, okay, this patient is a T3, N2, M0. So T3 is, the tumor is greater than 5 centimeters, so it's large. And then N2, walang N2 pala. Okay, let's say N1. And because some other cancers have N2. Let's say N1. N1, so it involves other regional lymph nodes. So there's lymph node involvement, and then M0. No distant metastasis. So T3, N1, N0. you are stage 3A. Okay? That's basically how it is. And how do we stage? How do doctors stage your tumors? They have to request a series of imaging. So, for anal cancer, it's usually a pelvic CT scan or a pelvic MRI, or even an ultrasound of the rectal ultrasound, anal rectal ultrasound. That's how they will know how big the tumor really is, and even the depth of the invasion, and even how if the lymph nodes are involved. And if they also check, usually they check like they check in the CT scan yung liver. Sometimes they would request for a chest x-ray or a chest CT scan so they can see the lungs. And that's how they'll know if there is a distant metastasis. Because once you have an M1, see, notice in stage 4, as long as you have M1, you are stage 4. It doesn't matter if the tumor is only like 1 centimeter, if you don't have lymph node invasion. As soon as you have an M1, you're a stage 4. So even if it's like a T1, N0, but if you're an M1, yeah, stage 4. Okay, that's how staging works. So you can like say, oh, lit-lit lang buko niya pero stage 4. Yeah, because kumalat na. Okay? Are you guys getting it? I hope this is I hope you guys understand this. What does metastasis mean? It means it's scattered to other organs of the body. Most common areas of metastasis for a cancer is liver, lungs, brain, bone. So, for we're talking about anal cancer, yeah. So, it can scatter to the liver. Usually liver, lungs, and that's what metastasis means. So, a certain tumor can be any size, but it will still be a stage 4 as long as it's scattered to other parts of the body. Usually liver, lungs, bone, brain. For anal cancer, it's liver. Okay? That's how staging works. So every time I'm gonna talk about cancer, if I'm gonna talk about cancer now, I'm gonna be adding the staging so you guys understand staging. So look, the higher the number is, the larger the tumor is. And also usually when if there's a T4 in a cancer, T3 will always be like the largest size that they can give. It'll be like a certain size and then larger. So like T3 is 5 cm larger. When they say T4, it means the tumor's invading another or adjacent organ. So like this one, it can be an anal cancer. A T4 anal cancer can be it can be 2 centimeters large or 2 centimeters small, but it is deep and invading another organ. So if it's in the anus, it can invade, like, for example, the bladder, or in females, the urethra, or the vagina. So it'll be a T4. Even if the tumor appears to be smaller, as long as it's invading another adjacent organ, then it's a T4. If it's a distant invasion or a distant the tumor is in a distant organ, it's a metastasis. Okay, you guys have any questions? Any questions before we go on? Because the next slides are just gonna be about anal cancer itself. And I guess there's none. Okay. I hope you guys are getting this. Alright. Squamous cell carcinoma of the anus. So this one is So out of all the anal cancers, this one is the most common one. So 85% of all the anal cancers or anal neoplasms will be squamous cell carcinoma. So the reason why it's called squamous cell carcinoma is because if you'll notice back here, where is it? Here we go, we're back to this. Remember I said last week, this part of the anus is made out of squamous cell epithelium, and if you go higher here, this is columnar epithelium. So squamous cell carcinoma means that the tumors came from here. The tumor is originating from this part of the anus. Okay? Squamous cell. And again, it usually presents with bleeding. And when you have a squamous cell carcinoma, since it's very near very near the anal verge or the hole, the butthole. Usually before, like in the old days, in the ancient times, not really ancient times, but years ago, decades ago, they just do straight up surgery. But nowadays, we're trying to come up with ways not to do straight up surgery. We're trying to, we start with chemoradiotherapy. Because what we want to do is shrink the tumor so that all you gotta do is just excise it. Because a surgery for anal carcinoma can be very radical. It's very radical. It's very life-changing. And if you're gonna be a surgeon, or if you're a med student, I don't know. I don't think med students need to know this, but if you're if you're gonna take up surgery, this is very important. You gotta know the Negro protocol. So this is what they use. If there is a squamous cell carcinoma, this is the chemoradiation therapy that they use. So yeah, 5-fluorouracil and mitomycin C, or mitomycin C and capecitabine, and then they add radiation. That's basically it. That is, when you say neoadjuvant therapy, it means chemotherapy or therapy before surgery. And if you say adjuvant therapy, it's after surgery. Okay? Is the chemoradiation not non-invasive? No, it's not. It's chemoradiation is basically getting chemo and radiation therapy. So chemo is, the medicine, and then you're gonna have some radiotherapy sessions. I have not seen how a radiotherapy is done. Actually, I haven't seen it, but I've seen chemotherapy being done. They just basically this. They just sit down on some comfy chair and then give you meds. There's like scheduled sessions for these, and they do this for several weeks. And then what they do is they monitor the size of the tumor. Okay, it's called the Negro protocol. It sounds offensive, but it's not. It's just called this because the guy who made this protocol, his last name is Negro. So that's why. Okay. That's his last name. So imagine if I can make my own chemotherapy regimen, it could be the Shiori protocol. Imagine that. Hey, this person has cancer of the foreskin. We gotta do a neoadjuvant chemotherapy. The ShioriPon protocol. That would be so cool. That man was locked in to name that protocol. Yeah. That would be so cool though. Imagine the ShioriPon protocol. Okay. Alright, so if neoadjuvant therapy is successful and the tumor gets smaller, all you gotta do is just excise it. You just remove it. Remove the tumor. If it's small enough and it's shallow enough, you just remove it. And you're good. But if if the neoadjuvant therapy is not effective, or the tumor still persists and it's still getting larger, then they're gonna have to undergo a very drastic surgery, which is abdominal perineal resection, or we call it APR. Okay? We call it APR for short. It's a very APR. Here we go. APR is a very radical surgery because, so imagine you have a cancer here. You're going to remove the anus, the rectum, and part of the sigmoid colon. And then you're going to make a colostomy. Okay? So you can see it here. The other end of the colon, they exteriorized it, or it's out here, and then they put a bag. It is a radical surgery because you change the physiology of the person. Meaning, you remove the anus. That means he is not going to be pooping out of his butt. He won't have a normal butt anymore. He won't have an anus. You removed it. You're gonna remove this, and then you're gonna close it. And he's gonna have a colostomy, and this is permanent. This is a permanent colostomy. That means after the surgery, for life, he's going to be defecating out of a bag, in a bag. That's why it's life-changing. And very radical, because, you know, you're basically, you're not like a normal person that defecates through a butthole or an anus. Your anus is now here, and you have to poop in a bag. So that's why APRs, this surgery is a lot of new doctors nowadays try to avoid this because it is a very life-changing surgery. That's why they come up with new kinds of chemotherapy, or, you know, neoadjuvant therapies to make the tumor smaller, so all you have to do is excise it, remove it, they don't have to undergo all this. It's even worse when the tumor is so big, the tumor is so aggressive and big that it invades adjacent organs. So in this area where the rectum is, the rectum is very closely related to the urinary bladder, and for women it's the vagina. So what happens is, if it invades the vagina or the urinary bladder, you have to remove those too. So imagine how very radical the surgery is, how life-changing it can be for the person. How's the logistics of the bag? Does the person keep buying bags? Yes, they will have to buy bags all the time. This bag can last for like, they will change it every now and then. Hindi naman siya araw-araw. It's not every day. Some people can have this bag for like a week long, and then you can change it. Some people wash the bag. You can wash the bag. But if it's pagdugyot na, di palitan na, diba? It's easy to take care. It's easy to actually clean a colostomy. It just looks very intimidating for new people. But I always tell my patients, if they have a colostomy, I tell them it's not hard to take care of a colostomy. Once you know how to do it, it's pretty easy. It's pretty easy. It's just a bit messy, but it's easy. I remember a Bantay Bata ad in the 90s about a kid who already has a colostomy bag. Cellophane lang pantakip sa colon ata sa tiyan nung nakita. Oh, yeah. Here in the Philippines, some people cannot afford a colostomy bag. Those are the lower socioeconomic class, where they can't afford an actual colostomy bag. They do makeshift stuff. I've seen it. They use a plastic bag. Tapos may parang rubber band or something or a belt. They make their own stuff, and it's interesting how they're able to come up with it, but also kind of messy. And if it's a child that has a colostomy, most likely that child has Hirschsprung disease. That is the most common reason why a child would have a colostomy, is because of Hirschsprung disease. Awkward na rin yung ganyan. I don't think I can handle bringing a colostomy bag all the time, so I pray that I'm lucky I don't have problems in my colon yet. Yeah, it is something like once you have a colostomy bag, it'll take a lot of time getting used to, but there are some people who get so used to it, like those who had this surgery early, they learn to live with it, like, you know, learn to live with it. It's something they accepted that, okay, I'm gonna be pooping out of a bag for the rest of my life, might as well live with it. And you know what they do? If you look around, they can decorate their bags. They have decorative bags for their colostomy. Like, they would cover it with like, wait, let me look. They would like, there's some people who make decorative bags. Colostomy bag decoration. Like, wait, let me look for one, okay? Oh, look at this. Here's one. Okay lang. Pakita ko sa inyo, ha? Look at this! Ito, look at this. They have freaking Snow White, Superman, and all that. Bruh. Pati sa Amazon, oh, may ganito. Ang ganda ng katawan, tapos may colostomy siya dito. There's even one right here. Like, some people actually, look, this one right here. They actually make decorations for their bags. So, you know, so it doesn't look like, you know, it actually looks cute. You know, cute eh. The moment you mentioned designing the bag, VTuber. Pwede rin, ha? ShioriPon colostomy bag. Decorate. Kawaii on the outside, full of shit on the inside. Actually, oo nga. Look at it. It's so adorable. Look at this. Colostomy bag decor. See? It's on Etsy. What? See, they come up with ways to, like, decorate their bags. It's cute, actually. It's really cute. So, these people, like, you know, they're so... You know they have a ano to? They've undergone a life-changing procedure, or they have a colostomy and they're like, you know what, I'm living with this, might as well decorate it. It's part of my body now, it's part of me now, I'm gonna decorate it. Colostomy bag na may decor ng Oshi nila. Yeah, imagine a HoloLive colostomy bag, no? Si Suisei, nasa colostomy mo. a Gerard colostomy. Imagine having a Gerard colostomy bag or a Avio colostomy bag or something. Umiiri pa ba sila or automatically floated? Okay, that one, in the beginning, some people are not able to control. The thing with colostomies like this, you have to plan it out. Before you do the surgery, you plan it out. You have to choose the right spot where to exteriorize your colostomy, and the most popular, the best spot to do this. Alright. Imagine, okay, we're gonna draw some muscles here, okay? So, we have, this is the rectus muscle, okay? Rectus muscle. You know, ayan, diba may muscle, yung rectus the strips of muscle that go here, like this, downward like this, is called the rectus abdominis muscle. Okay, rectus abdominis. The stoma, or this, is usually in a position in the rectus abdominis. Okay, rectus abdominis muscle. the reason why we exteriorize the colostomy on the rectus abdominis muscle is so that they have some sort of control over it. They use their rectus abdominis muscle, their abdominal muscles, to control the colostomy. So yes, actually some people are able to control it like a sphincter. So it's something they gotta learn on their own. So some people are unable to control it. Some patients are unable to control it, but you know, some people learn how to. They use their abs. Yeah, basically. Bowel movement. Bowel movement. Imagine. Bowel colostomy. Bowel movement. That would be so cute though. Hololive colostomy bags. Okay? So yeah. Cause I know a person there was a doctor I know, like an old doctor I know that actually underwent APR, and he's able to control his he's able to control it. Like, I think there are some people who have mastered controlling their colostomies that they don't wear a bag anymore. They don't wear a bag. They probably just cover it with something, and then like a small whatever, and then they just, you know, they are able to control. I always wonder how the heck that happens, because what if they, parang kung umutot sila, diba? Di mo sobrang baho kasi. Pag umutot, it's like directly at you. Yeah, Pokeri, when we do colostomies for elective surgeries, we plan it out. We really plan out where to put the stomach. Okay. Alright, next. Itututok sa kanila sa kaaway. Guys, imagine that. Uututan kita. Itataas mo lang yung t-shirt mo, tapos uututan mo talaga sila, no? Dude, it can be a weapon. Pwedeng no? Imagine this being a weapon. You can actually make it like a freaking poo-poo cannon or something. Anyway, okay. Alright, next. Okay, the next one. This is the last one. So, adenocarcinoma. Adenocarcinoma is anal cancer that arises from the columnar epithelium or the upper anal canal. So, this one is on the columnar part of the anus. So, remember, squamous cell carcinoma arises from here, but adenocarcinoma of the anus is a little higher in this area. So, it's higher. And once you have cancer here, anal cancer in this area, the treatment is different. The treatment is treated like it's a rectal cancer. So rectal cancer is a whole new different thing, and I will talk about that when I'm talking about colorectal cancers na. So, but anal adenocarcinoma is rare. Because as soon as you have adenocarcinoma, it's usually a rectal carcinoma. Not so much an anal. And it's only like 5 to 10% of anal cancers. So, rectal cancer, I will talk about this next time. Because rectal cancers, this one is more complicated than anal cancers. It has a different treatment, although it comes from the same, you would think anus and rectum are the same, but they're not. They are treated differently. Simply because the tissue or the cells are different. Like anus is usually squamous cell, but once you get into adenocarcinoma, it's treated like a rectum. And the treatment protocols for this is different from anal cancer. Okay, so, and I will talk about this next time. The next time when I talk about colon and rectum. Oh, here we go. Look, I even added this. I found this online. So, what is the difference between anal cancer and rectal cancer? So, anus. Remember, HPV. Avoid HPV at all costs. Make sure you don't have HIV. So, please practice safe sex. Ayun, anal warts, cigarette smoking. So, yung mga nag-yossi dyan, you are at increased risk of having anal cancer. Okay? Typical treatment, you also have chemotherapy and radiation therapy for the same, but the protocol is different. That's why it is similar in that you have to do a neoadjuvant chemoradiation therapy and then you do a surgery, but the types of chemo and chemotherapy you give is different, and the type of surgery is also different. Okay. Ako na single safe. Pero nag-yossi kayo. Sino sa inyo nag-yossi? And yeah, that is the last slide. Okay, that is the last. I hope you guys learned a lot from this. Ulan ba? Okay. Wala nang quiz. Wala nang quiz. Tinatamad ako. And I need to walk my dog. I haven't walked my dog in a while. Wala nang quiz ngayon. Next time na lang ang quiz nyo. I think my next medical education stream, I think I'll talk about something a little lighter. I think, did I ever talk about the, bed sores? Did I ever talk about bed sores? I don't know what to say. I think bed sores is a nice topic to talk about because a lot of people, bed sore is kind of common. Especially if you have a relative or you know someone who's bedridden and always on, so okay, here we go. Let me look at, here we go. Totoo daw ba na constant anal sex can cause incontinence? It's more like you damaging your sphincters. It's more of the sphincters because incontinence, it means your sphincters aren't working properly. So anything that causes the sphincters to lose their control would lead to incontinence. So yes, it can be that. Because that's, wearing out your sphincters all the time, stretching them out. Bed sore is more in blood flow. Yeah, bed sore is developing a wound on certain areas of your body. High pressure areas, or no. Yeah, certain areas of your body, and they become wounds. They develop, like as the name implies, bed sore. They develop in people who are bedridden, who are always in a bed all the time. I think we can talk about that one. That one is a very easy topic, and I think a lot of people. I think it would be good to talk about that because I know a lot of people can have bedridden relatives, your old lolo lola nyo, or whoever had a stroke or anything that makes them stay in a bed for a long time. You gotta know how to take care of this because, to be honest, bed sores are very. As a surgeon, okay, as a doctor, I personally do not like bed sores. They are very difficult to deal with. Bed sores are very hard to take care of. It is not easy. I don't like bed sores. That's why the best way, you know how they say prevention is better than cure? So if you know about bed sores, it's better to prevent a bed sore from happening than to actually treat a bed sore, because oh my god, bed sores are hard to deal with. As a even as a person, as someone who has a relative who takes care of a relative with bed sore, and as a doctor who has to take care of a patient with bed sore, it is a nightmare. It is a nightmare, man. It is not easy. So as long as you know how to prevent a bed sore, that is a lot better. Prevent it. Yeah, I'm gonna do it for next year. I'm gonna talk about, I think bed sore is a good one. Alright, so we are good for today. Thank you guys for watching my stream. I hope you guys learned a lot. Nga pala, nasa YouTube ako, so I can't raid. I'm on YouTube, so I can't really raid, or I don't know how to raid people. I don't think there's anyone I can really raid. Like, I would raid, hindi ako marunong mag-raid dito. Yeah. ShioriPon, guys, thank you for coming to my stream. I hope you guys learned a lot. I'll see you. Wait, my next stream is, I think I have a stream tomorrow. My next stream is tomorrow. Saan ba yun? God, I went to Twitch. I was going to Twitch. I'm like, no, that's not. I'm not supposed to raid anybody. I can't raid. Punta pa ang Twitch. Where's my schedule? Oh, I didn't pin it, that's why. Oh, tomorrow is Doom. Doom stream tomorrow on Twitter. On Twitch. So we're going to kill some demons. I gotta finish this game, yo. Friday night is Tekken stream. Tekken stream Friday night. Yes. Siguro next week will be Tekken with viewers. I think some of my Tekken viewers want to play Tekken with me already. They have been asking. And then Saturday, VR chat. We'll try VCAT again. I'm going to see what I can do to fix the lag. I have a feeling that the reason why I was lagging so much is because I use the wireless. I'm gonna try. The reason why I use wireless on my headset is because the wire, I don't know how to connect the wire to my PC. It doesn't work. It doesn't work as well as it did. So yeah, okay. I will look it up. But yes, guys, thank you for coming to my stream. I'll see you guys again tomorrow afternoon, 2 p.m. Hopefully, I don't have to delay my stream. Bye-bye, Yatsu!